Welcome to today's webinar. Today, I will be presenting From Feeding to Eating, Assessment and Oral Feeding Interventions for Infants with Tracheostomy Tubes. Our focus today will be early oral feeding experiences for infants with recent tracheostomy tube placement. My disclosures: I do have a financial disclosure in that I receive a speaking fee from Dr. Brown's Medical to teach this course today. Non-financial disclosures: I have no relevant non-financial relationships to disclose or to list. We have 4 primary objectives that I hope you will obtain at the conclusion of this webinar. Before we begin the session, I would like to thank the families and the infants for allowing me to share their infant story to advance our learning. I do request that the infant's information is not utilized outside of this educational event, but strictly to be used during this session to advance our learning. During this webinar, we will discuss the growing number of infants with complex medical conditions that require an artificial airway, primarily due to either upper airway obstruction and/or lung injury or lung underdevelopment due to their prematurity or comorbidities of prematurity. The placement of a tracheostomy tube oftentimes occurs during a critical neurological window of development when the infant is learning suck, swallow, and breathe coordination. Because of the timing and placement of the tracheostomy tube within the aerodigestive tract, these infants are at the highest risk for developing oral feeding delays or pediatric feeding disorders. The Today article from 2019 is a foundational article that provides for us a definition of pediatric feeding disorder, in which the infant can have impaired oral intake that is not age appropriate. In the Goudet article, they provide a hierarchy of infants' medical conditions or sensory experiences that can place infants at high risk for a pediatric feeding disorder. Children with tracheostomy tubes have the most severe forms of pediatric feeding disorder, as it encompasses the sensory, motor, and behavioral components of feeding. Now let's move into types of infants that may require a tracheostomy tube placed. In 2021, Fuller reported in the article on the update on pediatric tracheostomy, indications, technique, education, and decannulation, this nice schematic that outlines for us an infant's decision-making with their medical team and family during hospitalization, the decision to have the tracheostomy tube placed. And this schematic also outlines for us the trajectory of each step along the way for medical decisions regarding the tracheostomy tube. For today's webinar, we will focus on post-surgical and the first 3 to 6 months as infants are acquiring their suck, swallow, breathe skills. When we look at the Leoy article from 2018 that was published in the American Academy of Pediatrics, it further defines for us infants that require a tracheostomy tube. The vast majority of them, 44%, will require a tracheostomy tube because of their lung immaturity and or injury from ventilation at younger ages gestation. 39% of the infants requiring a tracheostomy tube will require the tracheostomy tube because of an upper airway anatomical anomaly or obstruction. And then you can see infants who have a neurological or neuromuscular condition would account for 6%, and our more complex infants with congenital heart defects, especially single ventricle anatomy, would account for 5%. Infants that do require a tracheostomy tube, per the Leoy article, typically wean from the ventilator around 15 months corrected, but will have the tracheostomy tube until well into 36 months corrected. When we take a deeper look at the lung pathology and the decision-making that goes into placing a tracheostomy tube, we are better identifying as smaller babies are surviving, specifically our 22 to 27 weekers, that not only do they have lung parenchyma health issues, but due to prolonged oral intubation, they can experience upper airway injuries, which can result in laryngeal lesions and or subglottic stenosis. In addition, these infants are also demonstrating persistent pulmonary hypertension due to the stress and strain on the heart in order to provide blood flow into the lungs for oxygenation and deoxygenation. We're very familiar with the diagnosis of bronchopulmonary dysplasia, as you see in the image to your right. We know that infants who are 36 weeks and older and are unable to come off of or wean from mechanical ventilation would be diagnosed with bronchopulmonary dysplasia. In addition, infants over 30 days of age who would require supplemental oxygen would also be termed with bronchopulmonary dysplasia. What is newer in the literature, as many of our smaller infants are surviving, has been nicely outlined in the Hansman article from 2021 that you will find in your reference section. In this particular article, they identify our infants that have significant bronchopulmonary dysplasia, but also find that 25% of them also have persistent pulmonary hypertension, which is an abnormal vascular remodeling and arrested development or growth of the pulmonary vasculature. Because the pulmonary vasculature is not able to have vasodilation, we see an increase in workload to the right ventricle of the heart, which can cause secondary heart failure. These infants require prolonged positive pressure from the ventilator and bronchodilators in order to preserve cardiopulmonary function. These are typically the babies at the highest risk for needing an artificial airway because of their prolonged need for positive pressure beyond term gestation. I also mentioned 39% of the infants who require a tracheostomy tube might require it because of an upper airway obstruction. So we know that the babies will be orally intubated when they are smaller. Then the ET tube can provide pressure onto the larynx and the mucosa. This pressure and the infant sucking on their ET tube can cause friction, which can result in laryngeal lesions. Over time, these lesions can also become ischemic and have granulation tissue formation, which would further close the upper airway. So in the images to the right, in the top image, you see the baby's airway as they have an occlusion or subglottic stenosis. And on the bottom image, you see how open the airway becomes after the ENT performs a balloon dilation. For this reason, we do want to track in our chart review the number of intubations a baby has had, if they've had an unintentional extubation and a traumatic intubation, and how long they require chronic sedation, because during chronic sedation, they can have an increase in laryngeal pressure of the ET tube. So those three components would put the infant at risk for having an upper airway occlusion, which could also impact their oral feeding ability after tracheostomy tube placement. Another subtype of infants requiring a tracheostomy tube would be infants that have an anatomical anomaly or airway obstruction. So the baby in the top image with Pierre-Robin has tongue occlusion of their airway, so requires tracheostomy tube with just a heat-moisture exchange. This baby does not truly need a ventilator, just needs an artificial airway as the upper craniofacial anatomy grows and or has surgical intervention from the ENT. The baby in the bottom photo has a lymphatic malformation, of which that lymphatic malformation would place external pressure on the upper airway, thus requiring an artificial airway below the level of the obstruction. Another classification would be infants with a neuromuscular condition. These infants have some different goals because these infants typically have very mature and very healthy lungs, but lack the muscle activation in order to produce an effective cough for pulmonary hygiene and health. As they fatigue, they can end up with nocturnal hypoventilation, and oftentimes these babies have very low tone. So our primary goals for infants with neuromuscular conditions who would require an artificial airway would be cough facilitation, airway clearance, secretion management, and progressing on to oral feeding. And finally, we come to the infants that have a central neurological condition. So infants that could have a genetic condition with a brain anomaly that would lead to underdevelopment of the brainstem where the breathing control centers are located. These could be infants that would not drive their own respiratory rate and would require prolonged ventilation in order for them to have a respiratory rate despite the use of caffeine or other neurostimulants to trigger brainstem activation. This could also be infants with severe hypoxic ischemic encephalopathy, as they not only could have brainstem injury, but a poor ability to manage their secretion and chronic aspiration of secretions, which could compromise pulmonary health. We recognize that there are many anatomical differences between the neonatal airway and between older infants and, of course, adults. We know that our neonates have a more anterior airway. We know the airway is much smaller, so is more prone to inflammatory conditions that could lead to an obstruction. Their tongue is quite large, as is their occiput of their head. The narrowest portion of their airway will be the cricoid, and their epiglottis is more floppy. So all of these differences within the neonatal airway can place them at an even higher risk for feeding and swallowing dysfunction once the tracheostomy tube is placed. So let's move into the implications of a tracheostomy tube. We're all familiar with the components of a tracheostomy tube. So we have the hub of the tracheostomy tube that you see on the image. The flange is the component of the tracheostomy tube that would be right up against the baby's neck. And then, of course, we have the cannula, which would be the inner diameter. When we consider the inner diameter, the goal would be that the inner diameter would only take up about 2/3 of the complete diameter of the baby's airway. When we think about a neo-sized trach versus a pediatric sized trach, the inner diameter is equivalent. It is just the length of the tracheostomy tube that would be different between those two sizes. When we think about the tracheostomy tube, we know that the size of the tracheostomy tube will allow for some leak. When there is some leak or airflow around the tracheostomy tube, we can hear an audible cough, some initial phonation because airflow will be flowing upward above the level of the tracheostomy tube to trigger the vocal cords. When we hear too much of a leak, some babies could be losing positive pressure, so adjustments might need to be made on their ventilator. When you look at the image to the right of your screen, you see a tracheostomy tube here that has a cuff. So this cuff is fully inflated, and so we see that inhalation and exhalation will exclusively occur within the inner hub or the cannula of the tracheostomy tube. The middle image shows a tracheostomy tube without a cuff, and as you can see, primary inhalation and exhalation will occur through the tracheostomy tube, but there's residual space here. And this residual space allows for the airway leak so the baby can start to get some upper airway flow into the subglottic region and into the upper airway. Not commonly used within the pediatric population would be a fenestrated trach, but for completeness of the course, I've included this diagram as you see primary inhalation exhalation through the tracheostomy tube, but because of the leak on either side of the airway and because of the hole or fenestration within the tracheostomy tube, an increased amount of airway can go into the subglottic region, into the oropharynx, and through the upper airway. Understanding leak is very important as we consider feeding interventions. When we take that same schematic and place that above the swallowing schematic, we want to really understand if the baby has a tracheostomy tube that has a cuff. You would know that if the baby has a pilot balloon on their tracheostomy tube. When the cuff is inflated, it increases the diameter of the tracheostomy tube and the space that it occupies within the airway. The issue with that is that with a completely inflated cuff, the infant on swallow with laryngeal elevation, the cuff can actually cause some friction and shearing on the inside of the tracheal wall, which can cause damage to the cartilage rings. So in an ideal state, we would want to progress the baby to either a cuffless trach that you see in the middle, or we want to be talking about cuff deflation during secretion management, swallowing, and oral feeding. When you look at the bottom images regarding swallow, so the yellow here is the bolus, you can see that as the yellow bolus is descending through the swallow, when the epiglottis closes here at my airway to protect, or at my arrow, when the epiglottis closes to protect the airway, the bolus needs to descend into the upper esophageal sphincter. If the tracheostomy tube cuff is inflated, typically beyond 1.5 mils of water or air, the baby could end up with bolus entrapment here because the baby would have a rigid airway with complete cuff inflation, which would not allow for esophageal expansion during bolus transit. So for this reason, we want to be very intentional about the flow rate of the bottle system that we're using, particularly paying attention to starting with an ultra preemie or a preemie flow rate to control bolus size so the baby doesn't end up with bolus entrapment. Bolus entrapment would be gagging or retching and lead to a significant maladaptive sensory response. So our inherent changes within the baby's sensory and motor characteristics of the aerodigestive tract just with placement of the tracheostomy tube. We see an increased risk of tracheal aspiration. It has been cited in the literature that infants who are working on oral feeding with a tracheostomy tube demonstrate a 70% incidence of tracheal aspiration, most closely correlated with fatigue. And of that 70% of tracheal aspiration, 95% of aspiration is silent because the babies haven't developed cough activation and they don't have vocal cord adduction to generate a forceful cough to clear fluid from the laryngeal vestibule if they would have had laryngeal penetration. From the schematics that we just reviewed, you can see that when a baby has a tracheostomy tube with a cuff inflated, they do not get upper airway flow, which then allows them to not have subglottic pressure above the level of the tracheostomy tube. Without subglottic pressure, the baby will not receive sensory input to drive a motor output. So we see that babies have a limited sense of taste and smell. We see them having poor sensation of secretion management because they're not getting a lot of upper airway flow, which equates to a reduction in sensory activation. And so we see a delay in motor output, which would be swallow activation. In addition, due to the critical need to provide securement to the tracheostomy tube, the trach ties or whatever securement device you are utilizing will limit laryngeal elevation during swallow. And so without complete laryngeal elevation, we can see an inability of the wall of the larynx and the epiglottis to completely close to protect the infant's airway during swallow. So again, without the ability to adduct their vocal cords or bring them together, because the tracheostomy tube is below the level of the vocal cords, we see infants having a very poor ability to generate a cough. A very poor ability to generate phonation, so crying, cooing, and babbling. Without use of subglottic pressure or vocal cord adduction, they lose the ability to control what we call intrathoracic pressure, so the amount of pressure within their lungs. And without coordination between intrathoracic pressure, you can see a mismatch between intra-abdominal pressure. So without true inhalation, exhalation, sensory input, motor output, we see more retractions in the rib cage during breathing, which then can lead to inactivity of the trunk for gross motor skills such as rolling, upright sitting, head control. And we also see these infants having a really hard time with Valsalva maneuvers to allow them to bear down and to have proper stool evacuation. Finally, as we're preparing to complete our chart review with these infants, we understand that ventilator settings will be critical to the sensory experience and motor experience of breathing. So we want to be conscious of the PEEP, the positive and expiratory pressure. The current literature recommends that infants be on a PEEP of 10 or less before we advance to true oral feeding with a bolus. We'll talk more about relative indications in a moment. We also want to think about pressure support. So that's the amount of pressure behind each breath. So how much help is the musculoskeletal system getting from the ventilator to reduce risk of endurance? Because as babies are losing endurance, as they are getting more fatigued, we can see more challenges with them coordinating their pharyngeal constrictors for complete swallow and bolus clearance. Of course, oxygenation is very important. The recommendation per the literature is an FiO2 of 50% or less before we would start oral feeding. And then tidal volume is a consideration regarding weight and size of baby. Infants will transition to a home ventilator prior to their discharge from the NICU or your subacute unit, whatever level of care these babies might be in. When we look at the home ventilator, what can be very helpful for the infants that are on the home ventilator and are working on oral feeding, if you are utilizing this type of trilogy vent that you would see here in this image, in the top right-hand corner where my arrow is, you can see percent spontaneous trigger. So that is how much musculoskeletal activation the baby is doing during breathing with the ventilator. We want that to be closer to 100%. We also can see the PEEP and the FiO2 on the ventilator for this baby. Many infants will transition off of conventional ventilator settings and work towards AVAP settings for their support at home. On AVAP settings, AVAP stands for Average Volume Assured Pressure Support. And the reason that the pediatric pulmonologist would want the babies to work towards AVAP, specifically your babies with bronchopulmonary dysplasia, is that this mode on the ventilator quickly modulates its pressure support and allows the infant to have more control over breath-to-breath variability. So breath-to-breath variability is the ability for the baby to modulate how much inhalation and exhalation force that they do. Coordination of swallow and breathing is very dependent upon breath-to-breath variability, as the infant will need to modulate their breathing mechanics during swallowing in order to have an efficient and energy conserving strategy to build their endurance for oral feeding. So this is just a brief video that shows you those ventilator settings and how those will be changing during inhalation and exhalation. So let's move into assessment and treatment for the duration of our talk today. I'm sharing with you a guideline that has been created and utilized within many NICUs and or subacute levels of care for initiating early oral feeding experiences. So once the tracheostomy tube is placed, during the surgical placement of the tracheostomy tube, the surgeon, typically an ENT, but could be a pediatric surgeon as well, will utilize stay sutures to stitch the tracheostomy tube in place, as the first 3 to 7 days are critical post-surgery for the maturation of the stoma. So during that time of 3 to 7 days, there will be very specific precautions in place. Most common, the precautions will be very limited or no out-of-bed activity, no transferring of the baby, but it is okay to start working on oral motor interventions to work on secretion management. So pacifier selection will be important. Once those stay sutures are removed, we can advance the baby to getting the baby out of bed and considering different positioning or postural control strategies to help the baby with secretion management. So swaddling, placing the baby in sideline and or supported upright. Of course, always having access to your oral suction and tracheal suction as needed for the infant's physiological stability and safety. If the infant demonstrates ability to have secretion management, I have listed for you the ventilator settings that I just cited in the past 2 slides. We would prefer the infant to have a PEEP of 10 or less. The reason we would like a PEEP of 10 or less is PEEP is the positive end expiratory pressure. How much volume is left within the lungs or the alveoli at the end of exhalation to prevent atelectasis or lung collapse. When the PEEP is higher, such as a PEEP of 11, 12, 13, 14, 15, then the infant's respiratory rate will be higher because there isn't as much inspiratory expiratory time. If you have a shorter inspiratory expiratory time, it does not allow for coordination of your swallow. So for this reason, we prefer the PEEP to be 10 or less because it allows time for the typical development of inhale, swallow, and then exhale. But if your PEEP is too high and your respiratory rate is above 60 or 70 breaths per minute, it's not going to allow the baby time to go into a nice inhale, swallow, exhalation pattern. We oftentimes see babies compensate with an exhale, swallow, exhale pattern, and we know that can be linked to laryngeal penetration and or tracheal aspiration with fatigue. As mentioned earlier, we would prefer the infant to be on an FiO2 of 50% or less. We know the act of oral feeding will be exhausting for the infant, so oftentimes we have to increase oxygen during the feeding in order to help them sustain physiological stability. If the infant has a cuff around their tracheostomy tube, we want to know, is the cuff inflated or deflated? Typically, your pediatric pulmonologists are going to want the cuff inflated so that we're not losing a lot of positive pressure on exhalation because we would control the leak. But your pediatric ENT physicians are going to want a deflated cuff or a cuffless trach in order to protect the walls of the trachea during functional activities, specifically secretion management and swallow. So we know that if the tracheostomy tube must have a cuff, for oral feeding or swallowing, we would like it inflated with sterile water or air to no more than 1.0 mils or less. Ideally, it would be 0.5 or less, but can be done with 1.0. Of course, we want the infant to demonstrate hunger cues and tolerate gastric feedings. The trial of the first bottle will be completed by the feeding therapist, and it is important that the feeding therapist be trained and fully competent in suctioning of the tracheostomy tube and oral suctioning. If not, having a nurse or a respiratory therapist present, because the act of oral feeding can generate a lot of airway clearance strategies, and the infant will oftentimes require suctioning in order to clear the airway. To start, we typically start with 1 bottle feeding a day with the feeding therapist, limited to 10 mils of unfortified human milk, preferably maternal breast milk if available. We like to use unfortified milk because it has more of a sweet taste, which we'll get into in a minute here with the next slides. And we prefer to use breast milk or human milk because it is so organic that if the infant does have some aspiration events, we know that the lungs are very resistant to an acquired aspiration pneumonia when we are using human milk, specifically if we can use maternal breast milk. So if the infant has limited access to maternal breast milk, saving that breast milk for oral attempts and then gavaging the supplemental feeding or the formula would be ideal. We would like to provide about 5 to 10 days of controlled practice with the feeding therapist of 1 time per day with a 10 ml limit. And once the infant demonstrates proficiency with those skills, we need to complete a standardized swallow assessment. So many institutions use a video fluoroscopy swallow study or a modified barium swallow study. Also, a FEES, a fiber optic endoscopic swallow study, can be completed, but many institutions still, for an infant with a tracheostomy tube, will prefer to use a video fluoroscopy or modified barium swallow study. Upon completion of the swallow study and with the results, the feeding therapist will work with the parents, the medical team, the nurses, and the respiratory therapist to create an oral feeding plan to optimize that neurodevelopmental window for suck, swallow, breathe, but also to not exhaust the baby from a pulmonary perspective so that the baby can continue to work on weaning of their ventilator settings. So let's move into some very specific behaviors that you will be looking for with each phase of feeding. So once the infant has their tracheostomy tube placed, you will be able to do a nice assessment of their intraoral anatomy or the inside of their mouth. Be aware that infants can sustain many anatomical changes due to prolonged oral intubation. So they can acquire a palatal groove or an intubation groove on their hard palate, which can cause a high arched palate and changes in velum activation. We're also going to be considering the sensory input and the motor output of anything placed within the infant's mouth. The gag response typically develops in infants between 26 and 27 weeks. So for infants that are intubated beyond the 27th week, oftentimes those babies can acquire a very hyperactive or hypersensitive gag response. So working very slowly in the anterior placement of the mouth with the lips and the gums to start, and then slowly desensitizing that intraoral cavity with your pacifier or oral motor programs. And then, of course, secretion management will be critical, how well the baby is managing their secretions, and you want to be prepared when you're working on your oral motor programs to provide oral suctioning. Ziegler and Zimmerman have published a number of articles regarding pacifier selection. There's a couple key components when we think about pacifier selection. So we really want to be thinking about the shape of the pacifier. So is it a slanted shape? Is it a standard shape? Is it an orthodontic shape? So the shape of the pacifier will have direct impact on how the muscles within the tongue work to allow the baby to latch. We also want to consider the integrity. So how much silicone load or how soft or firm each one of these pacifiers would be. We know from Ziegler and Zimmerman's work that pacifiers that have a higher silicone load or an increase in integrity provide more sensory input. So if the baby is having a hard time eliciting rooting and latching, you might need to consider a higher silicone load to start and then work them to different types and shapes of pacifiers. The other thing to really consider is the length of the pacifier. If the baby is showing a lot of gagging and retching, longer pacifiers can trigger that gag response. So you might have to start with a shorter pacifier or only offer the bulb of the pacifier to start to desensitize that gag response, because once the infant starts to gag, it can really trigger a fight or flight response. And we know that development does not occur when infants are in a fight or a flight response. Shaw and Schubert gave us some really nice information from their research on secretion management. We know that by working with a pacifier, it has been shown to facilitate relaxation of the upper esophageal sphincter. So when the baby tries to swallow their secretions, we need the upper esophageal sphincter to relax in order for that bolus to go into the esophagus. So facilitation of sucking and rooting will be very important to train the upper esophageal sphincter, that coordination of tonic relaxation and tonic closure. In addition, Shaw provided us with a lot of great information regarding the importance of sensory input, specifically taste. So we know that when we add taste, and hopefully the baby will have some air leak around their tracheostomy tube, so they have some sense of taste. When we add taste, specifically a sweet taste, it triggers primary peristalsis within the upper esophagus. So by using a pacifier and then offering either drops of milk, preferably human milk, breast milk, as it's very sweet, by doing dips with the pacifier in the milk, we not only can trigger relaxation of the upper esophageal sphincter, but we also can trigger primary peristalsis. Because remember, many of these babies, the esophagus has never had peristalsis. They've been dependent upon a feeding tube. So we need to train the esophagus to get going. There's a number of products out on the market, of which you see their pictures here. And these are specifically designed pacifiers that have a chamber so you can attach a syringe and you could slowly give a drop or two during your controlled oral feeding. So you could advance away from just dipping the pacifier in the milk, and you could give drops via these pieces of equipment to help babies coordinate the oral phase of feeding and to prepare the pharyngeal and esophageal phase for swallow with a smaller bolus. Speaking of the pharyngeal phase of development, we know that the aerodigestive tract is going to sustain some atypical developmental skills that we would observe. We would really want to be watching for in our assessment would be retching, any gulping sounds, head turning during these gulping sounds, or if their cuff is down, you could even hear some inspiratory stridor. Those atypical or accommodations that the infant is making can be indicative that in the pharyngeal phase is where we would really need to target our treatment. So from an assessment perspective, we're not only looking at PEEP on the ventilator, you really want to think about the cuff, if it's inflated or deflated. You want to think about controlling the bolus with the flow rate with your bottle selection, and also working with the infant to establish a cough, because we know cough will develop between 40 and 43 weeks, which is typically the time when infants are starting to have their tracheostomy tube placed. Other key interventions, it's very important that we provide head and neck alignment when we're feeding the infants, whether we're feeding them in sideline or in supported upright. We need the head and neck to be in alignment so the pharyngeal constrictors are at the appropriate length tension relationship so the baby can generate a good swallow. Many babies will have an excessive hyperextension due to positioning strategies to stabilize the airway when the babies were orally intubated. So oftentimes we can see a lot of tightness in their neck muscles back here. So really working on alignment and considering positioning of the baby side lying is typically where we're going to start. So the bolus can pool within the baby's cheek, and then the baby can coordinate the pharyngeal phase. Pending information from our standardized swallow assessment, we might even consider changing the thickness of the feeding, the viscosity, the flow rate, and the temperature of the fluid. We know that if we provide a cold fluid, that will trigger more vasoconstriction and sensory input, so the baby can have improved motor output with swallow. That same concept is true if we need to provide a thickened feed or increase the thickness of the feeding, because the bolus within the baby's mouth and the pharynx would provide more sensory input, which would allow for more of that motor output with swallow activation. There are many options on the market for bottles. You can see in this picture here. Some key things that we need to remember is that we really need to use a vented system, no matter what type of bottle you're going to be using. Some vented system will be critical because the baby will have a leak around their tracheostomy tube. So as the baby is working on swallowing the bolus, they could end up entrapping more air around that bolus due to the leak in the upper airway flow from the ventilator. So really controlling with a vented bottle system for aerophagia. We want to start with the slowest flow possible, so an ultra preemie or a preemie flow rate. Many of these babies have a very poor ability to open their mouth. So starting with a narrow base is very helpful so that they can get the vertical gap in mouth opening to allow their lips and tongue to come into proper alignment for the lingual stripping and seal, so the compression and suction required. Also thinking about the shape, there's different shapes of nipples. So the shape of the nipple is dependent upon how well the baby can cup their tongue. So if they're very good at tongue cupping, a standard shape might be more optimal. If they have very weak tongue cupping, you might have to go with an orthodontic or a wider shape to start, with the goal of transitioning them to a standard shape. During your first initial feedings, we really want to listen for aerophagia. So gulping of air, sometimes you can hear multiple swallows to control a bolus. So thinking about if the baby has a G-tube, venting the G-tube intermittently during their oral feeding experience. We don't want the baby to build up a lot of air in their stomach from swallowing air during swallow. And if they build up too much air in their stomach, they could have pressure on the lower esophageal sphincter and end up with an emesis event. Utilizing cervical auscultation is by no means a replacement for a standardized swallow study, but can be a helpful clinical tool. So the Franking and Menzen article are nice references for those of you interested. And so while we are bottle feeding the baby, we can be listening to the structures within their swallow mechanism. And so we typically hear what we call a clink. So that's when the bolus hits the valleculae. And then we hear a louder sound, a clunk, when the bolus transitions into the upper esophageal sphincter. So this can give us a nice way to differentiate if the infant is having challenges with the pharyngeal phase of feeding or the final phase of feeding, which would be this esophageal phase. So as previously mentioned, these infants will have been very dependent upon tube feeding. No matter what type of tube is being utilized, the esophagus is not being used for propulsion and bolus movement. So we can see babies having a really hard time with tonic control of the upper esophageal sphincter. So using your oral motor strategies or working on sucking on a pacifier will be very important to trigger that skill and to acquire that skill development. But the esophagus itself can be really limited in its ability to propulse the bolus from superior to inferior. So for these babies, typically we can hear a lot of stacking of the bolus. So we see the baby start to show a lot of extension during feeding. We can see them doing multiple swallows Even after you remove the feeding source, multiple swallows to try to trigger the esophagus for peristalsis, and we can see a lot of retching. So gagging is typically in the pharyngeal phase, but retching is typically in the esophageal phase, where the atypical or accommodation for the infant. So we would want to target our treatment there. For those of you that would be doing standardized swallow assessments, you might want to have a conversation with the radiologist prior to swallow study. And I would recommend panning down into the esophagus to make sure that the baby is not stacking the bolus. For those situations, you really do want to consider flow rates, really slowing the flow down or helping the bolus be smaller, and then integrating some spinal activation, because the esophagus does have that anterior attachment on the vertebrae. So when the baby is moving their spine, this is why you see a lot of back arching, lateral, specifically back arching and head turned to the right for babies that are trying to work on esophageal propulsion or elongation. So from a treatment perspective, we're going to be thinking about offering early opportunities for non-nutritive sucking. So immediately after tracheostomy tube placement, we're going to be thinking about spinal flexion and extension, considerations of controlling the size of the bolus. So primarily slowing down the flow of the bolus. Some babies might need alterations in the viscosity, so a thicker viscosity of fluid, so the bolus has more consolidation, and then it's easier for the esophagus to have peristalsis. We also do want to remember gastric decompression during oral feeding, whether it's breast or bottle feeding for infants with tracheostomy tubes. So let's move into case examples now. We've reviewed a lot of information on indications for tracheostomy tube, assessment, and intervention. So let's take a look at using some of these skills with actual patients. This is Ellie, and Ellie was born at 24 weeks and 6 days. She was 470 grams. In this particular video, her mom is feeding her with a preemie flow nipple, intentionally and supported upright to help with Ellie's esophageal motility as Ellie is weaning off of her gastrostomy tube. Ellie is 7 months corrected. So we'll just let this run here. So her mom is using a lot of the strategies that we talked about, supported upright, controlling the flow with a slow flow, using a vented nipple. You can see that Ellie is very comfortable. So this is what our goal is going to be for the infants that we work with. It doesn't start out looking this easy, but these babies do have a lot of possibilities when it comes to oral feeding skills. So let's take a look at Ariana. So Ariana was born at 22 weeks, 350 grams, very small. She had her tracheostomy tube placed at 43 weeks corrected. And in this particular video, this is her 4th bottle feeding attempt. So we're using a vented bottle system, controlled flow with an ultra preemie nipple. She needs more sensory input, so we're using a cold fluid. We're offering 10 mils of her mom's breast milk that is unfortified to elicit more of that sweet sensation to get primary peristalsis of the esophagus. So as you can see, she's going to have a lot of kind of head back and forth movement. She has some delayed latch, and she's very hesitant to bring her mouth completely onto the nipple because of her lack of sensation in her intraoral space. So we're going to provide just some really static input and support, not a lot of forcing for oral motor support, work on head and neck alignment, and just help her become regulated to having a feeding source within her mouth. This particular video, second video, is in that same session, but after about 10 minutes of working with the strategies that we just talked about. So again, using a controlled flow, with a vented system, just some very gentle support, almost static support at her jaw. And you can hear that little clicking sound. And that clicking sound is because she has a high arched palate. And so when she does have a lot of lingual stripping, because of her high arched palate, there's a little space between the standard shape of her nipple and her palate. So we hear that clicking sound. As we continue to work on oral motor intervention, as her palate and her head shape become more normalized, that sound should decrease. Initial swallow studies for these infants can look something like this. So you see the tracheostomy tube, and you can see the dark fluid. The baby will take a very, very small bolus because coordination of the oral and the pharyngeal phase is a novel or new task. For this reason, we oftentimes want to provide some practice feeding before we go down for a video fluoroscopy swallow study. But you can see as we kind of continue with our swallow study and with practice, she'll start to take bigger and bigger bolus. And with that large bolus that you just saw descend right where the arrow is, where the tracheostomy tube is, this is where we want to really train our eye to make sure that the baby doesn't have any stacking at the upper esophageal sphincter or stacking in the esophagus because of inflation of the cuff around the tracheostomy tube. So now we'll meet Ava, and Ava was born at 22 weeks. And when you look at Ava's face, you can see she has a very low tone tongue. She prefers to have tongue coming out instead of a nice midline tongue. And you can see on her upper lip a lot of elevation in her upper lip. It's hard for her to bring both lips together. So we're going to need to do some oral motor work with Ava. We are going to intentionally choose a pacifier with a high silicone load to give her sensory input. And we're going to give upward input into her hard palate. So her tongue will learn to come up towards her hard palate. We'll do this very shallowly in her mouth. So we'll do a little gum mobilization here to work on getting that tongue moving forward and back, and to reduce the risk of triggering her gag response. So oftentimes this can take upwards of 5 to 10 minutes before you can even start working on an oral feeding attempt. The next phase we would think about would be that pharyngeal phase that we talked about in our lecture. And so when we watch Ava, we're going to intentionally only have 5 mL of cold, unfortified breast milk in this bottle. And we're going to just provide some upward input into her hard palate. The nipple is unloaded, and you can see that she still has a lot of gagging and retching. She has a preference towards neck extension and towards spinal extension. So we're just going to work for a while on desensitization and positioning her in upright. After about 10 minutes, she does swallow without gagging about 2 mL of fluid. And can you hear all of the air that she swallowed? So for every 2 mL of fluid, she was swallowing about 15 milliliters of air. So really consider your gastric decompression. So we'll do intermittent venting of her G-tube. We'll clamp her G-tube, and then we'll continue on with her feeding. So after about 20 minutes, 10 minutes of oral phase, 10 minutes of pharyngeal phase, gastric decompression, she will progress to self-latching onto the nipple with a lot of supports from her feeding therapist without any gagging and retching. So these, I think, are just examples of layering those interventions to help Ava get the skills that she's going to need prior to us going down for her video fluoroscopy swallow study. For moms that have been vigilant with their pumping and have a strong goal for breastfeeding, the Van Osh article from 2022 outlines a really nice algorithm for healthcare providers and feeding therapists on decision-making and how to support infants with tracheostomy tubes on latching to breast, positioning, and controlling flow. So typically, once a baby has completed their video fluoroscopy swallow study and we have a better sense of infants' tolerance to flow, we can start making recommendations of if the baby would need to latch to mom's breast, if it was full breast, a partially pumped breast, or an empty breast, so having mom pump before baby latches, and then also considering using a nipple shield to provide better sensory input to the baby's intraoral space. There are many other additional considerations to support the development of the aerodigestive tract. So considering use of a one-way valve, so in this particular image, you see a Passimir valve, but there's a variety of one-way valves that can be utilized to help babies restore subglottic pressure, which would improve their sensory and motor skills with oral, motor, pharyngeal, and the esophageal phases. Also, progressing babies to purees or solids once they start having head control, because the bolus consolidation from the puree or solid will give them more of the sensory input to help with the motor output for swallow safety. I'd like to thank you for your attendance today. If any of you would have further questions beyond our question and answer session, or would want to contact me in the future regarding any of this information, I have included my email address on this final slide. Because ultimately our goal for these babies is to transition them from feeding as a newborn into eating skills, much as we see Ellie here, who is so comfortable with her oral feeding, and she is willing to start to do hand to face to the bottle and to support her own feeding source. And so optimally, this picture is what we hope for all infants and families, because feeding is such a bonding time for families with their infants, regardless of if they need an artificial airway with a tracheostomy tube.
Thanks, Holly, for your amazing expertise on this area. I know we are at the top of the hour, but if y'all could stay on for just about a few more minutes, 5 more minutes or so, I want to try to get some questions answered on this great opportunity we all have to have Holly here. And I'm going to go first with a question that's for all of us, the old timers here, because someone did ask this question. Do you ever still use the blue dye test?
Yeah, so we occasionally will still use the blue dye test. I would say we primarily use that for infants that have very thick, copious secretions. It is a nice way to assess oral secretions over a prolonged amount of time. So upwards of 12 to 24 hours, we'll keep a tracking log at the crib side to see if our nurses or RTs do suction any blue dye out. So we will occasionally use that. What we do know, though, from the literature, when we look at neonates and infants swallowing, infants typically when they swallow aren't going to have a lot of residue in their airway, even if they aspirate. And so the likelihood of us suctioning, if they truly would aspirate blue fluid, would be a little bit lower. So it cannot be a definitive assessment. So we really would still want to do a standardized assessment, even if you would have done a blue dye trial. But typically we're using that for infants with poor secretion management, like your neuromuscular kids or your genetic kids.
Great information. Thanks, Holly. How about, there's a question about, could you address swaddling in babies with trachs? Some of the practical questions here.
Yeah, so occasionally we will swaddle. So swaddling is really dependent upon the baby's rib cage activation. So if it is a baby who has an artificial airway because of bronchopulmonary dysplasia, oftentimes they have an increased work of breathing and they can show air hunger. And so if we're going to swaddle those babies, we're going to swaddle them at nipple level or below, and typically not their arms in the swaddle, because as they change their breathing pattern from inhalation to exhalation, they're oftentimes going to have to use their shoulders and their upper rib cage to make that accommodation. So it's really important, I guess, to look at their breathing pattern before you consider swaddling. If it is an infant who has a primary neurological condition, swaddling would be a very beneficial intervention during feeding to help give them containment and organization. So I think you'd really want to think through why the baby needed an artificial airway and watch for increased work of breathing.
Thank you. I know we're leading into more questions that could even be more webinars, right? You have so much information here. And,
Sure.
and you know, we don't get some of this information. I mean, we don't get a lot of this information, obviously. So for example, here's another just practical question about babies with trachs. Can tracheostomized babies with fully inflated cuffs burp?
Yes, they can still burp if they have a fully inflated cuff. It's a little bit harder for them, and their burp will oftentimes not be one loud, succinct burp. It would be two smaller burps. So in that scenario, if you've been orally feeding them, typically if they've taken a volume of about 10 to 20 mils, if they have a really small burp, you might still want to consider either trying to burp them again or gastric decompression, because the ratio with aerophagia of how much fluid they swallow versus air they swallow will be disproportional, especially in an infant with an inflated cup. So it is very possible, and you would want to for sure try that first, but be vigilant about another option for gastric decompression.
Okay. How about, is there an increased risk of aspiration if orally feeding an infant while on a vent versus waiting until they're off the vent? Or is it better to start oral feedings as early as possible, as long as they meet the vent recommendations for initiating feeds?
Yeah, that's a great question.
Yeah.
I had given you guys 3 slides of articles, and for that specific question, I really would refer you to the Sobotka article, Sobatka. And so what we know is that if we miss the neurodevelopmental window for suck, swallow, and breathe, those infants have even more significant issues with pediatric feeding disorder. So once the tracheostomy tube is placed, we really want to get going on all of their developmental skills, including oral feeding, following the recommendations that I've outlined on the slide regarding ventilator settings. Because if we miss that window, then we don't really have a strong foundation to start to work with the infant on future feeding. We know they're going to be on the vent for typically until they're 15 months corrected. So we wouldn't want to wait for that long of a duration before we would start their oral feeding journey.
Great. How about, I'm gonna ask a couple more because we still have most of the people that are on here.
Yeah.
Do you have an article that you recommend about bolus entrapment with the presence of an inflated cuff?
Yeah, Jenny, I saw your question. That's a great question. I would for sure have you read the Pullens, Pullens article. It's listed on the slide. And also the Henningfeld, Henningfeld. Both of those articles do a really good job of talking about hyoid bone movement and laryngeal elevation and the impact of a tracheostomy tube cuff. And so I think really understanding the anatomy and the physiology is what can help you open up those conversations. Your pediatric pulmonologists are going to want that cuff inflated in order to keep pressure down on the ventilator, but your pediatric ENTs are not going to want that cuff inflated to preserve integrity of the anatomy. So I would read through those two and then really open up conversations with those subspecialty physicians.
Great. Thank you, Holly. And just so everyone knows, that all of the references she is speaking of will be in the handouts, and the handouts, all of the information will be posted on our website when the recording is posted in a few weeks, and you'll get an email that tells you that, or you can just check back on our Dr. Brown's www.drbrownsmedical.com. All right. Well, we should wrap up for now. I want to just thank Holly for being here again. Her information is so, it's just, you have such expertise, and we're so happy that you're here with us today.